Hello, everyone. We'd like to thank you for the opportunity to provide a module on ab-interno canaloplasty, one of the minimally invasive surgical techniques for managing primary open-angle glaucoma. In the coming slides, we'll explore its mechanisms, indications, patient selection, advantages, and outcomes. Before we start, we have no disclosures to report. So to go into some basics about what glaucoma is, primary open-angle glaucoma is characterized by a blockage of the drainage outlets for aqueous humor, which leads to increased intraocular pressure and damage to the optic nerve. Open-angle glaucoma accounts for about 80% of all glaucoma cases and is the leading cause of permanent blindness worldwide. So as we can see in this figure right here, this is the normal anatomy where the outflow pathways are patent and the aqueous humor can flow from the anterior chamber into systemic circulation. But in glaucoma, we have a blockage of these outflow pathways, and this will increase the intraocular pressure, which then builds up and pushes on the optic nerve, causing irreversible vision damage. So the aqueous outflow pathway plays a crucial role in maintaining normal intraocular pressure. The trabecular meshwork pathway is what accounts for the majority of outflow. It's about 50 to 90% of aqueous humor outflow. And so we know that the flow of aqueous humor is segmental and pulsatile, and it's dynamic. And we can demonstrate this through aqueous angiography. We can also visualize the anterior chamber and angle through OCT imaging, as we can see here in the bottom right corner. So in regards to the specifics of the aqueous outflow pathway, we have Schlemm's canal, which drains fluid from the anterior chamber into systemic circulation. It's supported by the trabecular meshwork and lined with endothelial cells that help maintain a pressure gradient, which allows the fluid to efficiently exit the anterior chamber. When this system fails, it leads to an increased intraocular pressure. Understanding the biology of Schlemm's canal is key to appreciating the rationale behind canaloplasty, as it targets this specific area to restore physiological outflow without removing or altering any tissue structure. So after Schlemm's canal, we have fluid flowing into the collector channels. These channels transport fluid from the anterior chamber into the episcleral veins, which are critical in the outflow system as well. So they're distributed unevenly around the canal, with the majority of the collector channels located in the inferonasal and superotemporal quadrants. The segmental nature of these channels means that some areas may be more efficient than others. Understanding the physiology and distribution of these collector channels can help refine surgical approaches like canaloplasty and ensure that areas that provide the most benefit are given special attention. So given that, how do we reduce intraocular pressure in glaucoma patients? So traditional glaucoma treatments are categorized into medical, laser, and surgical approaches. Medications like prostaglandin analogs and beta blockers are often the first line, but long-term compliance can be challenging. So other options are laser and surgical approaches. Laser approaches include trabeculoplasty, and this can improve outflow, but may have diminishing effects over time. Surgical interventions, traditionally like trabeculectomy or a tube shunt implantation, are highly effective, but they come with their own risks. Some of these risks include hypotony, infection, and long-term bleb-related issues. Ab-Interno Canaloplasty aims to provide a safer, less invasive alternative that still offers robust pressure-lowering effects. So canaloplasty is a non-penetrating procedure that restores the natural aqueous outflow pathway by dilating Schlemm's canal. It was originally performed through an ab-externo approach, and it involved threading a microcatheter through the canal and applying viscodilation. The newer ab-interno approach allows us to achieve the same goals but with less tissue disruption, as it spares the conjunctiva and sclera. This makes it safer and easier to perform. And it can be performed as a standalone procedure or in combination with cataract surgery. In particular, the iTrack catheter system has a fiber-optic illumination guide, which helps the user visualize the catheter in the canal. So why do we treat Schlemm's canal? Treating Schlemm's canal directly addresses the site of outflow resistance in primary open-angle glaucoma. Viscodilation can enlarge the canal by 2 to 3 times its normal size, improving its capacity to drain aqueous humor. The normal size of the canal is about 250 to 300 microns, and the volume of the canal is 11 to 15 microliters. This process also helps break adhesions within the canal and dilate collector channels, which further enhances the outflow. By preserving and restoring this natural drainage system, canaloplasty offers a physiological approach to maintaining intraocular pressure without altering the structure of the eye in a way that traditional surgeries do. So this is a basic slide outlining the main indications and contraindications for canaloplasty. Canaloplasty is indicated for patients with open-angle glaucoma, particularly those with mild to moderate disease who are not responding to medications, or for those whose surgery is just the preferred method. However, it is contraindicated in neovascular or angle closure glaucoma and in eyes with significant scarring from previous surgeries. Proper patient selection is also crucial, and all patients should undergo preoperative gonioscopy to assess the angle anatomy and for PAS, which helps in planning the procedures and maximizing success rates. With regards to those on blood thinners, there is a potential increase for hemorrhage, and this is something to keep in mind when counseling patients. So one of the many canaloplasty devices on the market currently is the iTrack advanced system. This device will be the main focus of this talk going forward. So going into some of the features, the iTrack advanced system is the only canaloplasty device equipped with an illuminated fiber-optic catheter, which allows for 360 degrees of canaloplasty. It facilitates the precise delivery of viscoelastic to dilate the canal with a capacity of up to 100 microliters of hyaluronic acid-based OVD. This advanced design improves outcomes by providing consistent viscodilation, ensuring that the entire canal is treated effectively. On the right, we can see the laser light box that's used to provide a source of illumination for the fiber optic tipped microcatheter.
Now we'll talk about some of the features as mentioned previously of the iTrack advanced system. It's known for its unique features including the illuminated catheter, which aids in precise positioning, and the 360-degree approach, which also ensures comprehensive canal treatment. This method is less invasive than trabeculectomy, and it spares the conjunctival tissue. This is particularly advantageous if further surgery is required down the line. The device is capable of ejecting up to 100 microliters of visco, which is much more than the capacity of the canal. Generally, the visco of choice is Helon Pro, but some others include Helon GV and Pro Visc. The volume for all visco should either be 0.55 or 0.85 milliliters.
So this slide is just a brief overview of the mechanism of action of the iTrack catheter system. So the procedure involves catheterizing Schlemm's canal and gradually retracting the catheter while releasing viscoelastic under controlled pressure. In addition, the tip of the cannula is pointed and it can perform a microgoniotomy. This action dilates the canal, creating a more favorable environment for aqueous outflow. The use of an HA-based OVD not only dilates the canal, but also helps separate the inner and outer walls, enhancing its function and longevity. Along the same lines, here we have a brief step-by-step of how the device works. First, the device is primed to ensure that there's proper flow, and then the angle is visualized using a gonio prism, and the device is inserted through a paracentesis towards a nasal angle. After this has been done, the cannula is pressed up against the canal to assess for blanching. This will ensure that the catheter is about to enter in the right place. And then the illuminated catheter is then advanced through Schlemm's canal. And after it goes 360 degrees, it's then retracted while gradually releasing viscoelastic fluid in 3 microliter increments to achieve controlled dilation. So here we have a very short video of the procedure. We have visualization of the anterior chamber and angle with the gonio prism. Catheter is advanced through the canal, and as you can see, the light is blinking as it goes through 360 degrees. This is especially visible when the lights are turned off, as you can see right here. And as it's being retracted, the surgical assistant may be clicking the knob or turning the knob on the device to eject fluid as we go through. So in this video, we'll go ahead and see what some of the collector channels look like. As we saw in the previous video, the canaloplasty is done here by moving the catheter through the Schlemm's canal, dilating it, and then it's retracted as it releases viscoelastic fluid into Schlemm's canal. In this step here, we see the injection of trypan blue into Schlemm's canal, and as it seeps out of Schlemm's canal into the collector channels, we see some of the sclera kind of turning blue. This kind of tells the surgeon that the canaloplasty was done adequately, the Schlemm's canal was properly dilated, and collector channels were opened. This allows for the outflow of the trypan blue dye into the collector channels, and thus we can see that blue stain in the sclera area. So here we'll go into some details about postoperative care of canaloplasty patients. Compared to bleb-based procedures like trabeculectomies, The postoperative management of canaloplasty patients is much simpler. It actually resembles that of cataract surgery, with follow-up visits scheduled at day 1, week 1, month 1, and month 3. Immediately after surgery, the patient may stop all medications. Most patients can reduce or discontinue all their glaucoma medications, although this is adjusted based on IOP control and individual response. As a general rule of thumb, if the patient is on 3 or greater medications, they may continue 1. If they are on fewer, they can discontinue all. But it really is variable. This tailored approach helps optimize outcomes while minimizing the burden of ongoing medication use. So, over the past decade, there have been several studies that have come out evaluating the efficacy of ab-interno canaloplasty. Notably, Korber and others at 6 years, with 6 years of follow-up data with 27 eyes, have noted that there's a mean intraocular pressure of about 26.7%. For reference, surgical success is often defined as an intraocular pressure reduction of 20% or greater. Other studies, including those at 3 years and 2 years, indicate similar results, with intraocular pressure reductions greater than 30% and similar reductions in anti-glaucoma medications. So these outcomes highlight the procedure's long-term efficacy and safety, and it supports its role as a viable option for glaucoma management. So this study by Dr. Gallardo, evaluating the 36-month efficacy of ab-interno canaloplasty, highlights some important findings. As we noted earlier, iTrack can be done with or without cataract surgery, and this study actually breaks down the intraocular pressure changes in the groups separately. In both groups, in the iTrack plus phaco and the iTrack alone, there's a significant reduction in intraocular pressure, with over 80% or 85% achieving a greater than 20% reduction in intraocular pressure, and over 60% in both groups achieving greater than 30% reduction in intraocular pressure. Looking at the figure on the right, we can see at baseline, there are very few patients who are taking no medications, and at 12, 24, and 36 months, we see that that population of patients has risen greatly. So, as with any surgical procedure, complications can be expected. However, most of them in canaloplasty are often self-limited and not harmful. Some of the complications that are most commonly seen are hyphema, postoperative intraocular pressure spikes, and descendant membrane detachment. Generally, hyphema is self-limited and non-threatening and actually can be a good indicator that the canaloplasty was done in the right spot. Post-op intraocular pressure spikes are transient and they generally resolve within 2 days post-operative. However, if it hasn't resolved within a month to 6 weeks, the surgeon may perform a YAG laser goniopuncture. And with regards to descendant membrane detachment, this is not that common, but there are certain guidelines that come with where the detachment occurs and how it's approached. So if the detachment is 100 to 300 microns in height and 1 to 2 millimeters in length, and it involves the central cornea, or if it's greater than 300 microns in height and greater than 2 millimeters in length involving the central and paracentral cornea, there may be surgical management with decimetopexy or mechanical tamponade. Now we'll go ahead and discuss some clinical pearls that the surgeon should be aware of while performing the procedure. As noted earlier, surgeons should be proficient in preoperative and intraoperative gonioscopy. During the preoperative stage, if surgeons note issues found in the angle with gonioscopy, they can be further assessed with OCT imaging. During the intraoperative stage, if the surgeon is met with resistance while advancing the catheter, it's important not to force it further down. Rather, the surgeon should assess for a false passage. If there is indeed a false passage, the surgeon can retract and reattempt, or approach from the other side. It's important that the surgeon moves slowly along the clock hours, but also ensures that they do not stagnate in the same spot. During the retraction stage, the surgeon can have the technician count as they click the injector for about 30 to 40 clicks, and it can be titrated as well. So on the same note, we have some additional points that the surgeon should be aware of during the MIG surgery. It's essential to keep the anterior chamber well inflated. An extra paracentesis should be made about 2 to 3 clock hours away from the main incision. A marking pen can be used to mark the incision for the device to be inserted. The reason for this is that if the device goes through the main incision, it can collapse the anterior chamber and increase the risk of a poor view and even potentially a descendant membrane detachment. Surgeons should aim to pick patients who are cooperative and compliant with medications, and those who also have a lower risk for bleeding. As we know, this surgery is commonly done with cataract. And finally, surgeons should be sure to watch out for steroid response. As a quick summary, some of the key advantages of ab-interno canaloplasty include preserving the eye's normal anatomy, avoiding tissue excision or implants, and providing a reliable and sustainable method of intraocular pressure reduction. The ability to intervene earlier in the disease process with fewer risks helps bridge the gap between medical and more invasive surgical therapies. We'd like to acknowledge and thank Nova Eye Medical for their assistance with the slide content. And thank you for all your attention. We hope this presentation has provided you some valuable insights into ab-interno canaloplasty with the iTrack advanced system.